it was a lot to learn. I know that, for instance, when we're training, obs-gyns or sonographers, they tend to say it's overwhelming, even the first one. But trust me, as you do this, especially doing it in a commercial model where you're doing it as referral from other doctors, as referral from nurses. As we talked about last night, there's a strong possibility that your referral system will contain more than just other GPs. I actually talked to my chiropractor today because I had to go in to get I have a lower back problem. And he actually said that he would love to start doing MSK ultrasounds, but he just does not have the time with all his patients. And there's a podiatrist that he practices with. And as I told you, I had torn my Achilles some 8, 9 years ago, and so every once in a while it still gives me some inflammation especially when I run, because I'm an avid runner. I love to run. And so I was asking him, and he's like, yeah, that would be a really nice additional service, but there's nobody in this office that's going to have time. We don't even have time to do regular x-rays. Where would we have time to do ultrasound? He says, now I just refer it to the radiologist. So I think that there's a lot of commercial models that we can think about, you can think about. I actually had a big meeting today with the Kenya Healthcare Federation, and one of the things they're considering is putting point of care ultrasound in all their outlying rural clinics that don't have ultrasound already. So the clinics with ultrasound, of course, are utilizing sonographers, but the ones that don't have ultrasound, these women and patients have to travel kilometers to get to the radiology, and often it's overpriced and they can't afford it. So they're now thinking of trying to figure out how to train for rural areas or refer to somebody, but there's nobody in those rural areas. I know there's also a Rural Doctors Association of South Africa. You guys should also be looking into that to see, hey, how can you partner with them? Because they've reached out to us on multi occasions to say, can you train us in ultrasound? So there's a lot of opportunities out there, guys. There's so much opportunities out there, especially with this point of care stuff, because no one has actually tapped into it to a level that we're tapping into it with this commercial level. So just know that there's a lot of opportunities out there. Those of you who have scanned before, those of you who haven't scanned before, this is point of care ultrasound. So it's not rocket science. It's, I described it as this. When we started doing point of care ultrasound in Kenya, that was 4 years ago. In South Africa, it was about 6 years ago, 5 years ago to be exact. And we got a lot of pushbacks from the radiologists and from people that were like, oh, you're going to steal people's jobs. And, nobody, that's not a radiologist or a sonographer or radiographer should actually be doing ultrasound. So I actually thought about this, and my reply was, well, you know what? We all have stethoscopes and none of us are cardiologists. So how do you justify that? Because as a regular practitioner, as an obs-gyn, I use my stethoscope. I used to, when I practice, use it all the time. Every once in a while, I'll pick up something that says, you know what, guys, you guys need to go to a cardiologist, and here's the name of somebody I'm referring to. Using the stethoscope did not make me a cardiologist. It just made sure that I could pick up things that needed to go to cardiology. It's the same with point of care ultrasound. It does not make you a sonographer or a radiographer or a radiologist or a sonologist. What it does enable you to do is refer those patients that should either refer them back home or refer them to another specialist. That's what we need to do. And, you talk about writing up reports so that the doctors can answer your reports. All that, is involved in actually doing really, really good ultrasound, really good point of care ultrasound. So I say that to say this, there is a lot of opportunity out there that we are, should be taking advantage of, and hopefully will be taking advantage of. So, any questions about last night? Anything that you want me to go over? And because I think last night was a good eye opener to you, but I am prepared to go over anything that you need me to go over, just so that we can align with where we are. Because if you're not really sure about the physics and about the control, it's good to ask questions right away. So, any questions? Dr. Magaga, how are you tonight? How are you doing?
Hello, hello. I'm doing good. How are you, Doc?
I'm well. I'm well. Good to hear your voice. Good to hear your voice. Dr. Jasob, how are you doing today?
I'm well, thanks. How are you?
I'm well, thank you. We have a Dr. Tazwin. Dr. Tazwin, can we hear your voice? How are you doing?
I'm good, thanks, Dr. Joseph. I can't complain.
Great. It wouldn't help if we complained anyway. What area were you calling from, Dr. Tazwin? Where are you located?
I'm I'm in Cape Town,
You're in Cape Town.
Ye-
Okay, cool.
yes, in
Cool.
in Western
A
Cape.
shame, man. I just did a training in Cape Town about 2 weeks ago. I would have loved to have anybody in Cape Town stop down. Usually, one of the things I love to do is when I'm doing a training, especially if it's for nurses or other GPs, I love to have doctors like yourself who are learning to stop by because one of the ways that the doctors that I've trained in my past have told me the best way for them to learn is to try to train others with the little bit they already know because they find that the exposure and the atmosphere leads them to a more learning environment. So my next training actually is in Gauteng on next week, Wednesday and Thursday. So if anybody's in the Joburg, Gauteng area, is there anybody on the call right now that's in Gauteng?
Mm,
Dr. Jasob, did you say yes?
Um, I am in Gauteng.
Oh, you are? Okay. Well, we need to, I'm going to put I don't know if you have availability. If you do, I would love to have you come down and sit in our training. It's just obstetrics. It's for 18 midwives that are starting their obstetrics practice. Um, Starting POCUS in obstetrics. So it's a great opportunity for you to get your hands on the probe as a physician to go in there. Have you done, I forget last night, I know I asked, had you, Dr. Mangan, done ultrasound in the past? A little bit.
Yes, I've done a little bit in the past.
Okay.
Yeah, yeah. I was just like moving around the ultrasound probe.
Yeah, that's good, man. I'm
Yeah.
going to, I'm going to put my WhatsApp number in the chat right now. It's my US WhatsApp number. Even though I live in South Africa, I still maintain my US number. Please reach out to me if you guys are in the Gauteng area so I can make arrangements for you to come. I would have to get your name ahead of time to give it to the hotel and the sonographers that are going to be there, so they're making sure that you don't have to pay. So that would be really, really, really good. Really good for you guys to come by. Who else is in Gauteng? I know Dr. Magaga, let me see. Dr. Jasob, where were you located? She's actually off chat because she rejoined. Hang on. People. No worries, no worries. There you are. Let's put you back on the mic. There you go. You can unmute your mic now. Where were you calling from?
sorry, I just got disconnected.
No
I'm also in,
worries.
yeah, I'm
You're
in,
also there.
yes,
Okay.
yeah.
So this training is going to be in 4 ways at the Indaba Hotel. It's going to be Wednesday and Thursday. I'll double check the days for you, but I believe it's Wednesday and Thursday. Let me know if you guys can spend the days with us. I think it would be also advantageous to get to this, give you a head start to your clinical in-person part, which we haven't scheduled yet. So it would give you a good head start to that. Anybody else in Gauteng? Okay, so the rest of you are in the Cape or Cape Town. So both you doctors, I would love to have you. Trust me, in about 2 hours, I'll have you guys, I'll be using you as trainers for the nurses. So, and it'll give you a good chance to mingle with the nurses, to explain to them who you are. We're also starting the same program with the nurses. We haven't started yet. We were waiting to see how it worked with the physicians like yourself first, but now that we see that it is working, we're going to now be starting with the nurses. So I'll be introducing this to them at that time, and you guys would be great spokespersons. So please reach out to me. I don't know. I know you guys probably work all day and stuff like that. It would be great if we could have you for those 2 days. Okay, so tonight we want to talk about first trimester ultrasound. Actually, it's just going to be pregnancy. It's going to be separated. And before we talk about that, we have to actually set the stage for pregnancy ultrasound. One of the things we have to do is set the stage where we're looking at GYN, gynae ultrasound, because a lot of your patients that come in may or may not be pregnant. What are some of the things you may find, or what are some of the reasons that a woman may come in for a gynae ultrasound? And these are basic reasons. First of all, if you're looking at gynae ultrasound, it's separated into transabdominal and transvaginal. The majority of scanning is transabdominal. The majority that you will be doing is transabdominal. The transvaginal probe for your probes, I suspect is coming out within the next year, but it is not out yet. Transvaginal wireless probes that actually work are actually a very new thing. So what you'll be doing is looking at the uterine size, looking at the position of the uterus, and then looking at the adnexa regions just to determine that, do I need to send this patient to radiology for a more in-depth scan? So there are advantages and disadvantages to scanning with transvaginal. In my hospital, when we were scanning GYN, we actually eliminated after a while the need to scan transabdominal because we're a private hospital. A lot of the women could not, tolerate holding their bladder, and we found out that when you held your bladder, a lot of things go wrong. For instance, the patient before you, the woman that's being scanned before you, usually takes a longer time. And then you just don't have any control over that. So one of the things we did is we actually eliminated the need to scan. But this is in a large Washington, D.C. hospital, so it may not work in the situations that you're in. So you're going to be dependent on your transabdominal scans. The advantages of transvaginal scan is you see that it's a shorter distance to the target, right? You're using a higher frequency probe. Remember what we said last night about higher frequency probe. The higher frequency gives you the better resolution, but you're going to give up distance. But in transvaginal, you don't need that distance anyway, right? You get an early diagnostic picture of fetal viability, such as ectopic pregnancies, and especially the ones that are hiding in the fallopian tubes or behind the uterus someplace. It's a great thing to use if your uterus is retroflexed or retroverted, and it's useful for patients that are large body habitus patients. However, it does have a disadvantage. If you're costing it out, you're going to charge more for a transvaginal. You have limited penetration, limited depth. You can't see the global picture. Well, you wouldn't be able to see it years ago, but now our transvaginal probes have almost a 360, actually it's a little less than 360 degrees, especially if you're using the advanced probes. And if you're looking at fibroids, it's very difficult to evaluate a fibroid with transvaginal, and it's invasive. There's some women that won't want it. So if I'm looking at the normal uterus size and shape, it's about the size of a pear, the size of your fist when it's non-gravid. The length of the uterus, if you're looking at it in centimeters, is about 7.5 from the cervix to the fundus to 8 centimeters. So if you're measuring the uterus, you're going to measure it like this. This is the length and this is the depth. The width will not be seen on this image. What is this? This is the bladder. It had some reverberation in the bladder. It has some echoes. It's not supposed to have echoes, but it's because that the sonographer that was doing this had her gains turned up because for whatever reason she did. So it put false gains inside the uterus. And so if we're looking at a normal uterus, now look, this is the difference between now it's what we call anechoic, right? As we looked here, there were actually echoes, so it was hypoechoic, but those echoes were not real. Same uterus, different gain settings. So as we look at this now, we have this uterus here. It looks like a hockey stick. the end of a hockey stick. Here is the body. Here's the fundus of the uterus, the body of the uterus, and then the cervix of the uterus here. And then here would be the vagina, right? And this picture here is a longitudinal or a sagittal picture. How do I know? Because the uterus is in a sagittal cut. The patient's cephalic or head would be up here. The patient's feet would be down here, anterior here, posterior here. There's a small amount of fluid in the posterior cul-de-sac, but that is what we call normal amount of fluid. Every time, for instance, she could have just ovulated and there's fluid in the cul-de-sac. So that is normal amount of fluid. We don't expect to see any more. We see these things here are just intestines that are floating around her lower abdomen, usually transverse intestines, and a little bit of small intestines are down here. Now, we turn transverse, and this is the picture that we get. So we go from longitudinal to transverse. Transverse, same picture, but now this becomes the patient's right side, this becomes the patient's left side, because now we're going from sagittal, superior, inferior, to coronal, left and right. Same bladder, we're just at a different level, so the bladder looks a little different. So this is a normal, what we call anteverted, because the uterus is flexed forward. Now, the same uterus with a transvaginal image, you can see the difference. Now we're seeing ovaries on either side. Here's a large dominant, what we call a hemorrhagic follicle. Why do I call it hemorrhagic? Because it has internal echoes, and usually that represents a little bit of physiological blood that's inherent in all follicles. We've got 2 follicles on this side, but we can tell she's going to ovulate from her right side, because this is the right side of the picture. This is her transverse uterus. So same image as this, only we're now looking at it a little closer. Bladder is still full. I usually do not like to see a full bladder with transvaginal picture. That can be painful to the patient. If you're looking at a transvaginal scan, I don't usually like to measure the uterus transvaginally because I usually can't see where the cervix begins. But again, we said the uterus length is 7 to 8 centimeters long, and that's coming out 7 to 8.3 centimeters in a sagittal selection. And then transverse. Now, again, I usually don't like measuring it in transverse because I can't see remember we talked about establishing borders? I don't know if this is this is uterus over here. So normally I had the sonographer do this just to show you what I usually don't like. They usually don't like measuring it unless they absolutely have to. So if you're looking at an anteverted uterus, here's the vaginal canal, cervix is in here, the uterus slopes forward, and here's the bladder that we were imaging through. So we're imaging through the bladder to get to the uterus. Remember I said we had intestines swimming around? Here's descending colon and cecum and rectum down here, and that's what you saw when you were looking at this picture. It's all this is colon and intestines. Okay, anteverted uterus. Now, with a transabdominal picture, we have the endometrial stripe that should be present in any uterus that is premenopausal and any uterus that is not pregnant. As long as you have somebody of childbearing age and they're still ovulating and they're not pregnant, you should be able to see somewhat of an endometrial stripe. Now, it does depend on what part of the cycle that young lady is in, how thick the stripe is going to be, right? So if I see that stripe, I know I'm in the mid portion of the uterus. What I usually try to do is if I am scanning a gynae, I'll make sure before I measure the uterus, I'm not to one side or the other. And the reason I know I'm in the middle, I'm in the mid-sagittal plane, is because I see the endometrial stripe here. Right? So we can have what's called a retroverted uterus where the uterus is bent backwards away from the transducer. I'm using the bladder, but sometimes I can't see the fundus even if the bladder is full because it's bent away from me. And that is what you see here. So remember this versus that, okay? So that versus that. This is a retroverted uterus. It's every sonographer's nightmare because sometimes this one is average, but sometimes it's so retroverted that this almost goes off the picture. We can tell mid-sagittus, we still see the what? The mid-sagittal, what we call endometrial lining of the uterus, the mucosal endometrial lining of the uterus. Okay, then we have what's called a retroflex uterus. This is not just retroverted, it's actually flexed like an arm that you turn backwards and that's actually flexed backwards. This is actually my nightmare. I don't like scanning these. I used to have to do like CVSs and amniocentesis, early amniocentesis with these uterus. And imagine putting a needle through here and trying to reach this uterus without hitting this part. You got to reach down to this part. It becomes hard without hitting intestines. This basically is what it looks like. Now, you say this, Joe, looks normal. But if you look at this transvaginal picture, right, it's actually backwards. It's actually supposed to be flipped this way. How do I know that? Here's the transvaginal probe that's inside the canal, and I'm firing this way. If I look at a normal transvaginal picture, notice that this transvaginal picture is angling this way. It's angling up. It's angling towards what you would call the superior part of your image because that is a sagittal picture. But if you look at the retroflexed, it's angling completely the opposite way, okay? Okay, I'm going to skip the vaginal transducer placement for now, but let's look at normal ovaries with follicles. Whether it's transvaginal or transabdominal, here is a normal ovary, okay? I've magnified the image. I've decreased the depth, so I'm not visualizing anything down here, just the ovary. You can see my calipers, but you see all these little dark anechoic areas. These are all follicular cysts. These are all egg sacs, all follicles. And when we're doing IVF, we track these follicles. Anything over 2 centimeters or 20 millimeters, we measure and we track it every so often because that woman would have been going through something where we want to see exactly when she's going to ovulate. Here's a dominant follicle. This is what we'd be looking for if I was doing an IVF study, but we're not. A lot of women will come in complaining of right or left side pain, and when you scan them, you find this dominant follicle that's about near rupture. That is why they're in pain. Once that follicle ruptures, normal ovaries mid-cycle, this is what you see, okay? A lot of tiny, tiny follicles. The more childbearing age she is, the more follicles you're going to see. The closer she gets to menopause, the less follicles you're going to be able to see. This is all normal. Right and left ovary looks the same, okay? When you're doing whether it's a transvaginal or a transabdominal, you're going to be looking for a couple of things. You're going to be looking and assessing the endometrium to make sure there's nothing in the endometrium like a fibroid or a baby that shouldn't be there. You're going to look for any endometrial fluid. There should be no fluid in that uterus unless she is pregnant and it's amniotic fluid. You're going to measure the endometrium anterior to posterior dimension. So basically, here's the endometrial layer, and you can see my tiny calipers on this, anterior to posterior. This is a normal proliferative endometrium. So she's in her early days, about 5 to 6 days. The endometrium then should be measuring 1 to 2 millimeters. As you get late proliferative stage, later than 6 days, then this measurement, you see this now has a triple striped, what we call a triple stripe, right? 1, 2, 3. It now kicks up to 13, 14, 12 to 14 millimeters is what it will measure in the late peri-ovulatory stage. It means she's around the time that she's going to start ovulating, okay? If you now look at this, which is the same as this is the secretory phase, right? And a pregnancy is possible with a normal endometrial lining in the follicular study, okay? Here, if you look, you see these little dots here. These are also anechoic, but this is not ovary. This is her cervix. These are normal endocervical cysts, normal what we call Nabothean cysts, okay? Anything under 20 millimeters, I don't worry about. And then a normal transvaginal with coronal view. You can see now with the transverse coronal view, you can see the endometrium that has gone from sagittal to transverse or coronal, okay? And here's a normal sectorial endometrium against the triple liner, but I'm just looking at it close with a transvaginal scan, okay? This is a normal little bit of endometrial fluid that we see here. Again, anything that measures around 2 millimeters, I don't worry about. A lot of women will have endometrial fluid normally, okay? Normal physiological fluid in the endometrium. Now, if you look at the postmenopausal endometrium, you'll see that normal is 1 to 2 millimeters. It may be up to 4 millimeters if the woman is bleeding. If it's over 4 to 5 millimeters, consider this hyperplasia of the endometrial lining. This is when you refer to a gynae or a radiologist, because if she's postmenopausal, there should be no hormonal action to make this endometrium thick. We found that some postmenopausal women, they had a thickened endometrium due to the fact that they had a tumor that was secreting hormones still, or encouraging hormones to be secreted. So when we went looking with a CAT scan, eventually would find a tumor. And there you have, this is a case of a, if I remember, this is a postmenopausal woman. She had a thickened 8.2 millimeter endometrium. You can see it here on sagittal also. This is on transverse. That is on sagittal. Little bit of posterior cul-de-sac fluid, but that didn't concern me. What concerned me was this large endometrium, was this thickened endometrium for a postmenopausal woman. That was not normal. What we ended up finding on CT was a small tumor that was sitting in her pelvis, and we sent it out for biopsy, which I did not get the results on because I am not a radiologist. So when you're doing as GPs and you're doing a GYN scan of a non-gravid, non-pregnant, pregnancy test negative woman, you're going to be looking for a couple of things. Things that could show up is fibroids, ovarian cysts, complex masses, which means masses that are not solid, they're not cystic, they're both. And you look at the posterior cul-de-sac for increased amount of fluid. So with this woman came in complaining of bleeding, abnormal bleeding, and it was not her period. And then during her period, she had heavy bleeding. So as we did, and you can tell that this is a retroverted uterus because it's going the opposite direction. Here's the fundus. The reason we did a transvaginal is because she was overweight and we could not see. And there, right here, is a little myoma, a little tumor, a little fibroid under the endometrial layer for uterus. This is an extra endometrial uterus. So this is what I would call an intramural, or in the muscular layer of her uterus. Okay, small little fibroid here. Not a big deal. They are benign. Here is another fibroid that we found. This uterus is going the correct way. Another woman that came in and she had pain. Every one of her periods were really, really painful. When we scanned her, here is a subserosal fibroid. Why? Is because it's not in the mucosa. It's not submucosal like the other one. It's not intramural because it's not really in the muscle layer. It's actually in between the muscle and the skin, the outer layer of the uterus. You won't be probably asked to tell the radiologist what kind of tumor this is, but you're just going to have to know, is it in the endometrium, in the body, outside? There's also something that we call pedunculated fibroids, which I do not have an example here, but it's a fibroid that's completely outside the uterus. It's attached by a stalk, which you can't see with ultrasound because it's so small, but it'll be completely separate from the uterus. Again, a 2-centimeter ovarian cyst that we're seeing here, not a big deal, okay? Ovarian cyst you'll have to look for. This picture is inverted. What we did is to actually see it, the technologist that was doing it changed the black and white and changed it to really grainy. So basically you have the cyst here, you have the uterus here, and then you have the endometrium right here. Please stop me for any questions. Okay? Now, here is a cyst. Here's what we call a teratoma. Okay, a teratoma is a complex mass. You can see this mass here. It has both cystic and solid regions. And when they biopsied, they found little bits of cells that look like they belong to hair cells, sebaceous fat cells, and that is that's a teratoma right there. Okay, so this is a cystic teratoma. Just some good case studies for you guys. Okay. Here it was a woman with polycystic ovarian syndrome. We also found cysts on her kidneys, so we went looking around, and she had an ovary with a lot of cysts. Both ovaries were enlarged, and she was not going through any kind of infertility studies. The thing that you will find with polycystic ovarian syndrome, or POS, is that you'll have ovaries that are twice their size, and they both will have cysts scattered throughout them that are not normal follicular cysts. I said that you also need to look for fluid in the color sac. This, I think, is a normal amount. Usually my litmus test for fluid when I start actually being concerned is if the fluid comes up to the body of the uterus. If it's now occupying this space, that means for some reason she's either bleeding, or there's some cyst that has ruptured, or if she's under IVF study, she may be hyperstimulated. Okay? This is a longitudinal picture. The sonographer here was good enough to write longitudinal here. And also, if you look up here, a lot of times your machines will tell you exactly what it's doing. This machine is, if you start reading this, you'll know that the frame rate is 18 hertz. A lot of information that you won't need to know. It's 1540 meters per second, which means it's scanning through soft tissue. Just kind of trivia. Okay. Another thing that you guys will find is IUDs. You'll do a scan and you'll find something in the uterus. You'll say, what the hell is this? It's an IUD. This, you already know what an IUD looks like. However, when you see it in ultrasound, this is what it looks like, because you're scanning it sagittally here, which means you're going along this axis of the IUD. You may not see the thread, okay, but you'll see the body in sagittal because you're scanning in this plane, so you won't see this unless you go transverse. So here's your longitudinal. It's a bright echo, right? And you should have at least 3 centimeters from the tip to the edge of the fundus. That's how you know it's not perforating the uterus. So this is a properly placed IUD, okay? Again, if you look at it here, this section right here, the cork section right here, is what you're seeing right here, okay? If you go, this is the normal, again, normal, this is a transvaginal. If I go transverse, you see it across here. No, actually, that's sagittal. Again, I don't have a transverse picture of it because usually we're not imaging it in transverse. However, you notice that this is a normally placed IUD. Here is one that we had that was a migrating IUD. You see the difference, right? It had migrated outside of the endometrium, went through the myometrium, and is now poking, okay, from the cervix all the way through the muscle of the uterus. That is not normal. It should be through here. So the distance from the IUD, you're going to measure the distance from the IUD to the edge of the fundus. You want this to be not more than 3 or 4 centimeters distance from this. Okay. Here is, oh, this was a good one. I remember this one. Here's a 25-year-old amenorrhea patient. She was having no periods. She was having really bad pelvic pain, and she found herself to be pregnant. So when we scanned her, the technologist said, let me do a quick cervical check, and lo and behold, the IUD was still there. Not a really, really good thing. Okay, so summary of point of care GYN. 1, know your normal anatomy. It's very simple. It's uterus, it's adnexa region, it's ovaries, it's cervix, it's vagina. You're going to evaluate the endometrium, right? You should know that the endometrium should not be thick in a postmenopausal woman, and you should know that if she's childbearing, try to figure out what stage she's in, and you can match it to the thickness of the endometrium. If you see an IUD, make sure it is not migrated and it's situated right in the endometrial cavity. You, in fact, sometimes don't see the endometrial cavity if the IUD is sitting correctly. And then you also have to look for adnexal masses such as pedunculated fibroids, uterine fibroids, teratomas. We have a lot of what we call chocolate cysts or endometriomas. Anything abnormal should not be in the adnexa or should not be in the uterus. Any questions? Okay, so I see there are no questions now. So are you guys still with me? You guys doing well? Give me a thumbs up. All right, thank you, Doc. Thank you. So now, first trimester point of care. Here's where you're going to be referring your cases out. This is where I need you to have a really strong referral base. Remember, your commercial model is only good as the people that refer to you and the people that you refer your patients to, right? You may write up a report and tell the doctor that you're marketing your services to, or even if you're working on your own, that you know what, this needs to be referred to a radiologist. And then what I need you to do then is actually establish some relationships with the radiologist. We have a training company here in South Africa, and one of my partners is a radiologist, and he routinely takes referrals from point of care nurses and other people that are doing point of care, because sometimes they have no idea what's going on. They'll say, hey, doc, we see this. It looks like the baby's head is a little abnormally shaped. Can you take a closer look? There's nothing wrong with that. In fact, it helps you because it one hand washes the other. Then that radiologist is quick to turn around and say, hey guys, you know what? We can't take these patients, but there's a point of care GP up the street, and I know that they'd come and do the patients, or we can refer to them because they have their own office. So first trimester point of care, what do we need to know? First of all, what are you looking for in a first trimester scan, right? A lot of your patients will present to you, some not know they're pregnant, some will try to bypass obstetric doctors, and this is when I send them to midwives. Less expensive unless they have an abnormal pregnancy, right? So what do we do? What do we do with a first trimester scan? Well, the first thing that we're looking for is, and your first clue that is a first trimester scan versus a normal gynae scan, will be the presence, location, and size of a gestational sac. So you have to evaluate the gestational sac. Where is it? What's the location of it? Is there a yolk sac in that gestational sac? What's the size of the gestational sac? How many gestational sacs do you see? And do you actually see an embryo or a fetus? That gestational age, therefore, is then going to be correlated with the CRL, which is the crown rump length of the embryo. Do you see a double deciduous sac sign, which I will show you? Is there fetal cardiac motion with the M mode? M mode we spoke about last night. Can you still evaluate the uterus, the adnex of the cul-de-sac? Okay, and these came off the AIUM, which is the American Institute of Ultrasound and Medicine, of which I used to sit on the board. So they're very friendly and very cooperative when we tell them that we're doing these kinds of things. So transabdominal, usually that's how I do a first trimester scan. Woman comes in, I'm having pelvic pain, or I'm having abdominal pain. It's right here. You tell her to fill her bladder, you scan, and lo and behold, she's pregnant. Okay. It's appropriate to see a pregnancy after about 6 to 7 weeks of gestation with a transabdominal scan. Most first trimester pregnancies are going to be picked up that way. Okay, so the effect of the bladder, remember I told you that the bladder acts as a window. So if the bladder is not distended, the uterus then becomes too anteflex, too close to you, and you cannot see because it's kind of like putting your hand right up to your face and then trying to tell me how many fingers are in it. So I need the bladder to be filled so it pushes the uterus back so I'm able to see the endometrium of the uterus, which is what I want to see. That is why you want a full bladder. Now, with a first trimester sac, you're going to be able to confirm an IUP. A gestational sac is seen from about 4 to 5 weeks menstrual age. So if she's coming back with a positive pregnancy test and she says, you know, her last period was 4 weeks ago or whatever, you should be able to see if she's pregnant, a tiny gestational sac. You may or may not be able to see a fetus within that sac or embryo, but you'll see a gestational sac with a double deciduous sign, okay? Now, a yolk sac is usually visible within the gestational sac when the sac size is about 8 to 20 millimeters, which correlates with a 5.5 week gestational age, right? And you're going to visualize that thick myometrium around the gestational sac, right? And that is called the double deciduous sac. Okay, so gestational sac is seen for 4.5 to 5 weeks. Embryo is seen 5 to 6 weeks, and the actual amniotic membrane is seen at 7 weeks. Okay, so here is a gestational sac at 4.5 weeks. All right, we did a transvaginal simply because she did not have a full bladder. So we see what we call a double deciduous sign. You see what I mean? It looks like a donut. It's actually the endometrium opening up to allow for the gestational sac. This is what you see. If the pregnancy is not a true pregnancy, if it's what we call an anembryotic pregnancy or a blighted ovum, you will not see a double decidua. You'll only see a single decidua, which is like this. This is your first clue that it is not a normal pregnancy. Again, let's look at it again. We blew it up a little bit for you. Here is the double decidua. You can see it on sagittal. You can see it on transverse, W decidua going all the way around. The sac itself is measuring 27 millimeters, 2.7 centimeters. And you see a tiny little embryo here with a flicker. If the picture was live, which when I measured this is going to correlate to a 6-week, 3-day pregnancy. Blow that up a little bit more. Use my depth on my equipment. Again, here's the gestational sac. Here is the W decidual sign going around it. This is the yolk sac, perfectly round. When I say perfectly round, I don't want it looking like a rugby ball. I don't want it looking like a football. I want it perfectly round. A sign of chromosomal abnormality is a yolk sac that is misshapen. Right here is where you would be looking for, right, the heart flicker, the heartbeat. It will be between the yolk sac and the myometrium. This is all should be anechoic, no echoes. And here we need to thank the texts that did this, the sonographers that did this. Here, yolk sac. Remember I said here's the amniotic sac here, okay? This is where the baby will form and grow an amniotic fluid. This is the chorionic cavity. This will go away because as this amniotic sac grows, it'll eliminate this chorionic cavity. Amniotic cavity, yolk sac, amnion. Again, same thing, gestational sac, yolk sac here. Sometimes you won't see the fetus or the embryo because it's too early. You tell her to come back in a week, come back in 2 weeks, and you should be able to see it. Now, this is a 7-week, okay, 7-week intrauterine pregnancy, cervix and gestational sac, W decidua sign, amnion present. Here's the amnion. Here's the baby in here. Little peanut. What we do then is we blow that up and we measure from end to end of what we call this embryo, and that gives us the gestational age. Never use the gestational sac measurements on your machine for gestational age. It is going to give you the wrong gestational age every single time because it's movable. If the bladder is full, it'll be smaller. If the bladder is empty, it'll be bigger. You see the sac here, is the gestational sac here is shaped differently than the gestational sac here. So don't use it for a measurement. The embryo here can be measured from head to tail or from tail to head. We can't tell which is which, but we measure the length, and that CRL is usually good within plus 3 or 5 days. So if you do, let me scare you a little bit. If you do the first dating on this ultrasound, you are responsible for that baby's growth. What do I mean by that? Because everybody else is going to look and say, hey, wow, Dr. Magaga did a dating, and when he did a dating, the baby was 5 weeks. And so now every measurement is going to compare to that dating. So if you're wrong, her gestational age will be wrong. Not to put you guys on the spot. Okay, same thing now with 7 weeks, 4 days. We use crumb rump length till about 12 weeks, and then we start measuring baby parts. And we'll get to that. This mom had a little bit of vaginal bleeding during her pregnancy. You can see a little bit of blood here in between the actual womb and the myometria. And we just follow that to make sure it doesn't get bigger, and it did not. Now is when we start really, really seeing a nice baby. We get to about 10, 11 weeks, and this baby now looks like this. And now I'll actually measure from the head to the rump. And, you know, my sonographers also evaluate nasal bones and things like that, but you will not be tasked with doing that. Nuchal translucency is down here. You can see the difference between this is a very nice nuchal translucency, very nice, no trisomy baby. Yesterday, I talked about M mode. And with M mode, what we have is the machine assigns anything that moves a motion. So what I do then is you find the heartbeat, you put your cursor right down the middle of the heartbeat, and these little blips here, either the machine will measure for you or it will tell you where to measure. And as you measure, it will give you a fetal heartbeat. Some machines measure every blip. Some will ask you to measure every third, every fourth. It depends on your particular type of machine. This machine was every fourth to get the average. And here you can see the heartbeat is 175 beats per minute. Around this, it should be no more than 180, okay, and no less than 150. Same thing here. This baby's starting to move. This is what all this crap is here. The baby's starting to move and the machine is picking up the movement. But we can still see the little blips as heartbeat here. Try not to use Doppler on a baby. Use M mode instead. Now, you're going to have to identify the number of fetuses. This is always a surprise to me. When I first started and when I was doing my residency, I actually missed one of these. I missed a twin gestation. My chief resident never let me forget it. So be very careful that you scan through the uterus. Here is a pregnancy that is a monochorionic diamniotic pregnancy. How can I tell? I see two amnions. I see an amnion here, and then I see a little V here, and then another amnion here. Okay, this is a monochorionic. Why is it monochorionic? Because as I look here, there's only one placenta. This area here is going to be what forms the placenta. Now, sometimes I can't see the placenta and I can still tell it's monochorionic because there's a very thin, very, very thin separation between these two twins. The only thing separating them is amnion, right? Because you see that little V here, the only thing separating these two are amnion. If you don't see any separation between the twins and you can see the amnion, then you know it's a monochorionic because there's no other separation. If it was a dichorionic, you would have something like this, right? Where you have a thick split between the twins. Now I know this is going to be two separate amnions and two separate placentas. This, one placenta, two amnions. Know the difference. I would look this up, become very familiar with pictures. You can find them all over the internet. The difference between a mono-di and a mono-mono or a di-di. The best situation you want is a di-di. Diamniotic, dichorionic. That's a low-risk twin. This is a high-risk twin. This twin, we have to follow very closely, okay? Also, if the twins are mono-mono, monochorionic, monoamniotic, it becomes a very high-risk twins. That is not followed by a midwife. It is not even followed by an obstetrician sometimes. It's followed by someone like myself who has experience in high-risk fetal assessments. Again, monochorionic, okay? You can see two amnions, but a very, very thin, very, very thin, very, very thin separation. That's the difference. When you have a dichorionic, the separation is very, very thick. So 12 to 14 weeks, you can do a crown rump up to 14 weeks. I tried to stop it around 12 or 13. But for your, since you guys are doing low-risk patients, you're going to do it up to 14 weeks. You can still measure the crown rump length. Remember, it's plus or minus 3 to 5 days. After 14 weeks, we now have to start looking at biparietal diameter, okay, composite gestational age. They're better predictors of gestational age after 12 weeks. Don't use them before, okay? Only in high-risk situations where I'm suspecting like amniotic band syndrome or skeletal dysplasia will I ever measure BPD before 12 weeks. Follow the second trimester guidelines for BPDs, okay? And this is a chart, you'll have this available to you, but your equipment will calculate all of this for you. You guys are so lucky. When I was learning, we had to calculate this on a hand calculator. Before every mom was released, we had to go through these calculations. So your equipment will calculate this automatically for you, okay? If an abnormal pregnancy is suspected, how do I know, right? You listen to clinical history. If she's had massive amount of pain, you look at her HCG levels. Is her HGC levels double what it should be, right? If it is a high risk abnormal pregnancy, you're looking at, has she had other ultrasounds? Is she just finding herself in your office because you happen to be contracting your service to an emergency room or something like that? So you always want to pull her HCG, her human gonadotrophic hormone levels. That has to be pulled. I will not diagnose any kind of pregnancy, early pregnancy, without seeing this, because I've seen molar pregnancies where this number is 3 times higher than it needs to be. I've seen twin pregnancies where this number is 3 times higher than it needs to be. So I need to know that I'm not missing something. I need to have that correlation, okay? A lot of times you know, the lab may not get that back to you, but you need to have it to diagnose these kinds of things. Refer, if you don't know, refer it out, especially pregnancies. Don't play around with them. So more case studies for you, okay? Here's a subchorionic bleed, subchorionic hemorrhage. Very normal pregnancy in here. You can see the amnion, the fetal pole. This is probably around, I would say 8 weeks. I can't see the yolk sac anymore, but then I see all this stuff under the myometrial layer. This is a bleed. Here is something that you should remember. The pregnancy has a very, very, very dim prognosis if the bleed is bigger than the gestational sac. Remember I said that. It has a very, very dim diagnosis if the bleed is bigger than the gestational sac. This mom ended up aborting in 2 days, okay? Because the bleed just kept going. It kept, whatever was causing her to bleed in the first place just kept going and going and going. So she ended up aborting this pregnancy. So again, just remember I said, if it's bigger than the actual gestational sac, then it has a very, very poor prognosis. We see gestational bleeds all the time, okay? But a lot of times they're so small and they resolve themselves, okay? So we're not really worried about them. This one did not resolve, and this mom ended up aborting before 9 weeks. Again, a bleed. You can see the yolk sac, you can see the baby's head here, the amniotic sac, but then she has this bleed going under. This one actually ended up resolving itself, but you can see it's smaller than, and this one was, I think she was in an MVA, motor vehicle accident, and she just developed a bleed, but within a couple of weeks it was gone. So a patient like that, you won't be managing that patient. She'll be in an obstetrician's office getting a scan every 2 weeks from a sonographer. Okay? Just know that the overall rate of first trimester miscarriages is about 12%. The higher rate of loss is prior to 7 weeks. That's why you hear a lot of women say, I don't like to tell anybody I'm pregnant before my first trimester is done, okay? The rate of loss after 8 weeks drops to about 3.6 weeks. Just some trivia for you to know, so that when you're scanning somebody in their first trimester, you're looking for bleeds, you're looking for any reason that you could tell them that they could be aborting the pregnancy, okay? What is the diagnosis of early pregnancy loss? Unfortunately, I've had the misprivilege of being in a lot of counseling rooms to counsel parents when they've had a loss. And believe me, it doesn't, in my 35 years of practice, even when I was practicing, it never got easier. So and embryonic gestation. Remember we said there's a double decidual gestational sac. This one has no double decidua. There's no double decidua here. It's just a gestational sac. And the gestational sac is misshaped. You see that it's not that nice round shape that we had. This is a misshaped gestational sac. The diameter is 27 millimeters, and I should be seeing a fetal pole, but there is no fetal pole, there is no activity. So an embryonic gestational sac is going to be irregular. There's no yolk sac present, there's no fetal pole, and there's no cardiac activity seen anywhere in this sac with no double decidua. Okay? Also, I want to see her beta HCG because that will be a nice thing. Even though you can have a positive beta HCG with an embryonic gestation, it still gives you a clue as to what's going on. Fetal demise is something that I do not like to diagnose. I did not. Here is a fetal demise. Remember that blip, blip, blip we were seeing on the M mode? There's nothing here. Okay, that is an early pregnancy that the body has chosen to abort. And this mom usually goes on to abort the pregnancy. If not, we give her like a day or so, and then we do a DNC to clean out the uterus. Okay, but it's an absence of fetal heart rate on M mode. Confirmation of fetal demise. M mode becomes your best friend with this. So if the crown rump length is less than 7 millimeters and there's no heart rate noted, you have to wait and rescan. And this is, the American Institute of Medicine, by which we follow, says we wait and rescan in about a week, because if there's no heartbeat in a week, she's going to probably miscarry anyway, or eject the products of conceptus. But now if you do a week, then you can be sure that it is truly a baby that has passed away. If you use the beta HCG levels in IUPs and ectopic pregnancies, they have a considerable overlap. A single beta HCG measurement does not distinguish between an IUP, intrauterine pregnancy, and ectopic pregnancy. You need serial levels to see if they're rising. It was thought before, when I learned that if the intrauterine gestational sac was consistent, right, on ultrasound in normal pregnancies whenever the beta CG values were above 2,000, but that has proved to be not true. In fact, I have had in my lifetime one pregnancy that was a heterotopic pregnancy, and that was in my second year of practice, about probably close to 32 years ago. And it's the only one I've ever seen where the woman was pregnant in her uterus, but then as we started looking around, she was complaining about pain, pain, pain. We sent her home. She came back a week later, and the sonographer found an ectopic pregnancy on her fallopian tube occurring at the same time that the uterine pregnancy was there. That is possible. Signs of fetal demise is basically you have a abnormally large yolk sac. This yolk sac should not be as big as the gestational sac, okay? Or you have an abnormally small yolk sac, okay? But no gestation in there, no fetal heart rate. The way that we usually manage first trimester fetal demise is we correlate the history, the physical findings, and the beta HCG with what you're going to tell me that you found with the ultrasound examination. If I get to trust the GP, I sometimes don't repeat the entire sonogram. I just have the sonographer take a quick sneak peek, right? We counsel the patient regarding the result, and then you're going to refer the patient as indicated. Okay, we talked about a pregnancy, but here's a pregnancy that's occurring the same time with a corpus luteum cyst. A lot of times we see these dominant cysts that just won't go away. Some of them we've even excised because they get so big, but this one went away. So don't be surprised if you see a nice pregnancy here and then there's a corpus luteum cyst there. It is not abnormal. Okay, you keep watching. Remember, now I told you guys a lot of information will be on this side of your screen. What this machine is telling me is that I'm penetrating this uterus at a 7-centimeter depth. I'm using a curved transducer C that is has several different frequencies in it, starting at 5 and ending at 9, okay? And the frequency that I happen to be using right now is 5 megahertz, okay? So you can get a lot of information from what you're looking at. Baby's heartbeat is 131 beats per minute. So let's talk about ectopic pregnancy, pregnancy from unknown location. Look, mom comes in, you have a positive pregnancy test, but you cannot find a sign of a pregnancy in that mom. You know the beta HCG is saying she should be 8 or 9 weeks. You're scanning all around, there's nothing, right? No intrauterine gestational sac, no fluid. She needs to be referred. Okay, because she's going to be referred to follow up those beta HCGs. If they continue to rise, you need to suspect that there is an ectopic or a pregnancy of unknown location going on. Okay, you could have inconsequential adnexal finding, which includes corpus luteum cyst, small amount of free fluid. A lot of times we may not see the ectopic pregnancy, but that beta HCG that keeps rising tells you there's something going on. In this particular lady, there was no uterine intergestational sac. She had a perfectly normal endometrium with a triple layer, right? Which I would expect to see in somebody that was just getting ready to ovulate. But as you go looking around, when you go with the transvaginal, there is a pseudosac as I go in there with the transvaginal. That means there's a little bit of fluid. Now, remember, I told you a little bit of fluid in the uterus is not a big deal. However, a little bit of fluid in the uterus when her beta HCG is positive is a big deal, because that's telling me that some way, somehow, there's those human gonadotrophin hormones are being activated by something, okay? The classification of endometrial, most of them that you will find will be in the isthmus or in the cornua, and you won't be able to tell. You'll just know that upon biopsy and upon evacuation, that's where the surgeon said that they were. Very few. I've seen one cervical in my life. I've seen one abdominal. I've seen a lot of ovarians, but most of them have been in this region, in either the isthmus or the cornea, because as the egg travels through here to try to get to the uterus, sometimes it just gets stuck. Sometimes there is scar tissue. It can't travel, and it just implants and starts to grow. Here's a tubal ectopic pregnancy that we excised. You can see it here. And this is the fallopian tube. The uterus is over here, rich with blood supply, but this was the ectopic pregnancy that we excised. Okay. We do have ectopic pregnancies with viable and non-viable fetal pole. This one was a adnexa. This was an ovarian ectopic pregnancy. You can see the fetal pole here. A not normal gestational sac. There's no, I don't see an amnion, and it's very abnormally shaped. And this fetal pole was not active. There was no heartbeat in the fetal pole. Okay. As I looked at the uterus, nice endometrium, but nothing in the uterus. Little Nabothean cyst here, nothing in the uterus. But as you go looking around, you find this in the adnexa, the right adnexa. Here's another one. Here's the uterus here. Here is an ectopic pregnancy that's sitting in between the left ovary and the uterus. So more than likely, it's in that isthmus part of the fallopian tube. She ended up losing the left ovary because we couldn't excise it without getting rid of the ovary in the tube, and the ovary was starting to torse on itself anyway. So we actually ended up taking that out. Ectopic pregnancies, you do not want them to rupture. So the minute you find them, you want to refer it quickly so that they can be, they can go to theater and get this thing either methotrexate out or actually removed from the theater. Here's another ectopic pregnancy. Here's the uterus. This one is sitting on, again, right between the uterus and the left ovary was up here. So yeah. This is the left adnexal ectopic pregnancy. It should be in here, but it is not. It is out here. This was an ectopic pregnancy that we found. The ectopic pregnancy was here, but she had started to rupture. The ectopic pregnancy had ruptured, and she was now bleeding into her belly, into her pelvis. So all this is blood, ectopic here, uterus here, and that gives her a free trip to the operating theater. Okay? Whenever you see blood, free trip to the OR or OT, depending on which country you're in. Okay? The symptoms of ectopic pregnancy will be all the same. 90% of these ladies present with unilateral lower abdominal pain. 50 to 80% of them present with active bright red vaginal bleeding. 60 to 70% of them will tell you that they don't have a period. They're amenorrheic. And that's because they're pregnant. The classic triad is you're going to find pain, no period, and vaginal bleeding. When you have those three things together, okay, it is present in about 48% of patients with ectopic pregnancy. So if you have patients telling you, and I'm going to add a fourth one, which says positive pregnancy test. Positive pregnancy test, vaginal bleeding and pain, as well as no period, suspect an ectopic. There's ectopic pregnancies that can also be caused by post-cesarean scars. And there's a high risk of maternal morbidity when that happens. More than likely, you may not see any of these ectopic pregnancies, but just know that they're asymptomatic with some vaginal bleeding, little bit of abdominal pain. They're high severe risk if they are pregnant. You need to get them out and referred immediately. If you notice that this patient has a cesarean scar and she has an ectopic at the same time, please refer that patient. Okay, referral is absolutely necessary. You do not manage this on your own. In fact, if you've contracted your service out, you don't even write up a report and send it. You call the doctor and say, hey, I'm seeing something that I think may be an ectopic. I'm sending her to your office. Please take a look. No questions. No questions. Okay, this is just a nice case study for you. You won't be doing this, but my technologist that was doing this is a proficient technologist at Doppler. So this was an intrauterine pregnancy, normal, but this patient was complaining about right adnexal pain, and it turns out she had this huge ovary with a huge hemorrhagic corpus luteum cyst. This is hemorrhagic because this cyst should be anechoic. It should look like this in here, and the cyst is filled with blood. So she was bleeding into the cyst and putting pressure in her pelvis. It eventually ruptured, but then she had a lot of blood in her pelvis also. Okay, corpus luteum will also have what we call a halo effect. When you hit it with Doppler, it has a rich blood supply to it. Okay, and here is a mass in the adnexa. Okay, we didn't classify it. Adenomatous mass is what we called it. Again, we referred this out to a GYN surgeon. Just some interesting case studies so you guys can get an eye. Here's a pregnancy with multiple fibroids. Oh my gosh, I hate these because these fibroids make it impossible for me to see this baby sometimes. Was there a question? Okay, I'll move on. If there's no question. So fibroids make it hard for me to see the baby because fibroids have a fair amount of calcium, especially if they're old fibroids, and they reflect sound back to you just like a gallstone. Luckily, we could come through here and see the baby. So here's the baby, here's a yolk sac, gestational sac, chorionic sac. Here's a huge fibroid here. Here's another huge fibroid here, and I'm suspecting there's one down here in the cervix also, but we didn't measure that one. This is a painful pregnancy because as this pregnancy grows, it irritates these fibroids. And this woman, they're going to be in pain. A lot of these women with multiple myomas have very difficult pregnancies. So when you find the myomas, just notice the measurements, measure them, and tell me where they are. This one is body, this one is fundus. And there may be one down here in the cervix too. I would have to decrease my frequency to see it. Oh, yeah, this one I hate. I always hate diagnosing these. Any idea what we're looking at here? This is a uterus, and it's inside the uterus. Any idea what we're looking at? I wouldn't expect you to. The first one I saw was at 2 o'clock in the morning. I was on call by myself in the GYN ward. Woman comes in just to scan her baby because she was coming, she was being discharged and they wanted to scan real quickly. Her beta HCGs were triple, and I thought I was going to find twins. But lo and behold, this is what her uterus looks like. Any idea what that is? Okay, this is called a molar pregnancy, right? It's called a hydidiform mole. This is a molar pregnancy. It's when the uterus is filled with just material that is not baby and thousands of cysts. This one needs to go for evacuation of the uterus right away. A hydidiform mole is what we're looking at there. It's the causes. We won't go through the causes because I could be here forever with those. It's just know that it's not a normal pregnancy, and you will see it really quickly. These have been linked to certain types of uterine cancer also. So this needs referral out right away. So summary of our first trimester scanning. What do I want to say? Number one, okay, look for where the baby is. Number two, establish how many babies there are. Number three, establish if there's two babies, is it diamniotic? Is it monoamniotic? Look through some pictures on Google to try to figure out where you are and what you're doing. Okay, because if it's a multiple pregnancy and you do not tell your referring person that it is a multiple pregnancy, you will find that you will not have a very good name in the medical field after that. Okay. Also, try to identify where the baby is in the uterus. Is it in a normal gestational sac? Is the gestational sac normal? Is it abnormal? What do you have with you? Okay. Now, let's open it up for questions. That is the end of our first trimester lecture. Any questions, guys? You guys must have questions because first trimester it's rough. It's very rough. And when you get used to it, though, it will become apparent to you as you do it over and over again. Any questions? Paul, how are you doing? Dr. Paul?
Sorry for joining late.
No worries. No worries. How are you doing today, sir?
I'm good, thank you.
Good. Any questions about first trimester scanning? Is this something you've done before?
Yes, I have done the first trimester ultrasound. So
Excellent.
the question is, if a fetus is not seen inside of the uterus, do you have to go look somewhere else?
Good question, Paul. Thank you for asking that question. The question is, if a fetus is not seen inside the uterus, do I have to look someplace else? Let's assume, Paul, that we have a positive pregnancy test. Are we assuming that? Okay, I'll take
Yes.
that as a yes. If you do not have a positive pregnancy test and the beta is 0, the present pregnancy test is negative, no. Don't go looking anywhere else for a pregnancy. You won't find one. If you have a positive pregnancy test where the betas are telling me that she should be above 5 weeks pregnant, you definitely have to start looking in the adnexa, look along the ovaries, look in the posterior cul-de-sac, look along the cervix. Make sure there's no free fluid seen, because one of the first signs of a ruptured ectopic pregnancy is blood in the pelvis, right? But remember I showed you the normal physiological blood that's usually in the cul-de-sac versus a cul-de-sac that where the woman is bleeding into it. So your signs of a hang on one second. Your signs of an ectopic pregnancy will be a mass that you can't identify what it is. It will be fluid in the cul-de-sac, okay? It will be it could be an abnormal shaped sac within the uterus, but in answer to your question, please look all over the quadrants of the pelvis before you tell them that you don't see anything. And even then, what I taught my residents to, even when you don't see a a ectopic pregnancy in the presence of a normal beta, of a positive beta HCG, what I would write on my report is I would never say there's no ectopic pregnancy. I would say that at this time, the pregnancy test is indicative of a gestational that's 4 to 5 weeks. However, no pregnancy seen without the uterus, which cannot rule out the presence of ectopic pregnancy. And then they're going to follow those betas up. If those betas continue to rise, she needs to go to a high-risk gynecologist. So I hope that answers your question. Very good question, though. Very good question. Any other questions? Let's see. Who will I pick on? Who will I pick on? Dr. Tazwin, how are you?
I'm good, thanks. On that same topic, with the beta HCGs that are rising, when then would you do a follow-up ultrasound if you haven't seen anything before? If you haven't seen anything in the adnexa or in intrauterine with a positive beta HCG?
So we do serial beta HCGs every week, okay? Unless the patient comes back, because if the beta HCGs are like 3-4 weeks, then I follow it up. Usually in the US when I was practicing, it was every 4 to 7 days. I would follow that beta HCG up. If I do it in 4 days and it's still maintaining the same level or dropping, then I'm not as worried about it. But if it's rising and I still am not seeing anything, then now I'm starting to get concerned, because remember, betas double, right? If it's doubling and she is symptomatic, then she's going to have to go in for a scope. Definitely go in for a scope. If it's doubling and she is not symptomatic, then I'm scanning her with ultrasound. If it's doubling and I can't explain it, then I refer her out to somebody high risk.
Okay.
Thank you, doctor. Good questions, guys. I don't know. You guys have really good questions.
Can I ask another question?
100%.
You said that we use the gestational sac at around 14 weeks and the crown rump length thereafter.
No.
If there's I mean,
let's reverse that. We don't ever use the gestational sac for gestational age measurement, ever. Okay? When we see the fetal pole, we use the crown rump length up until 14 weeks. And then after 14 weeks, we start using biparietal diameter. Yeah,
that's what I mean. So if there's a discrepancy at around 14 weeks, do we then use, which one do we prefer? If let's say we did the crown rump length and there's 13 weeks and 2 days, but the BPD is 14, would something like that ever happen? Or
yes, absolutely. There's always a disparity within, and you always have to make sure that it's within whatever the machine says the standard deviation is. So for instance, if I measure the crown rump length and it's coming out at 13 weeks, 5 days, there's a standard deviation of plus or minus 5 days. Okay, so if I then measure the BPD and it's still even if it's coming out at 14, it's still within the standard deviation, I'm always going to go with the more exact measurement, which is the crown rump length. Remember, doctor, anytime you introduce variables into your measurements, you then work on inconsistency. So if I only have one measurement, right, then it's going to be a lot more exact than if I'm measuring 2 measurements. And the BPD is actually 2 measurements that you're measuring, right? So what you want to do is keep to the crown rump as long as you can. After 14 weeks, you now go to BPD. But however, when you've already set the gestational age with your crown rump, can I also tell you guys something? Do not change gestational ages based on the fact that you're getting different measurements. The babies don't grow according to plan. For instance, when I was in Cancun and you're doing ultrasounds in Cancun, you'll find that the femur age, right, in your ultrasound is always less than the femur age than if I'm in Kenya. Why? Kenyans are taller. They're going to have longer femurs. Doesn't mean I'm going to change the gestational age. It just means my standard deviation is going to be allowed to be more. If you're measuring a crown rump length and it said the gestational age is 14 weeks and she's due May the 2nd, and then next week you measure like the BPD and now it's saying she's due May the 8th, Do not change it to May the 8th. It is still May the 2nd. If you keep changing the gestational age and she actually is going through some kind of growth restriction, you now have nothing to base your restriction on because the target is always moving. Keep the target the same. And that's why I'm saying to you guys, when you measure that first crown rump length, that now becomes viable. That is what every doctor that looks at your scan is going to be going through. So if you refer to me, let's say that there's something wrong with this baby and you say, hey, doc, you're a gynae, you're an obstetric doctor, I'm referring this baby to you. I'm going to say, well, Dr. Mayona, what did you find when you measured this baby 3 weeks ago? You're going to say the baby was measuring that her gestational age was 13 weeks and her due date was May the 2nd. That is exactly what I'm going to use, right or wrong. So we're going to hope that you're right. It's really important that you get that first measurement. That first crown rump length is what is never going to change. It's ever going to change. If that first crown rump length at 5 weeks says that the gestation, that her estimated date of confinement is May the 2nd, it always is going to be May the 2nd. Everything is going to be benchmarked against that. I hope you guys understand that. That's very important for me to relate to you. Dr. Magaga, any questions?
Not at the moment. Thank you.
Perfect. Okay, so we are going to actually close up. You guys this is fantastic. I mean, I can't wait to see you guys in person. For those of you who joined late, is anybody in the Gauteng region next week? For those of you joined late, I already asked my early joiners this. For those of you joined late, is anybody in the Gauteng region next week? The reason I'm asking is because I'll be doing a training with 17 nurse midwives, and it'd be really great for you guys to come by and take part in the training for free. There will be no charge for that. And then also I can actually start training you guys to be trainers, because that's another, believe it or not, that is another commercial model that Chad has not even gone into yet, is because when we train for POCUS, we use trainers and they are paid. So yeah, this would be a really good thing if you're in the Gauteng region. My phone number is on the chat. If you click the chat, you'll see my WhatsApp number is there. It's a plus 1240 number, okay? And if you want, just go ahead and message me on that WhatsApp. I'll put it in there again in case you lose the thread. And just tell me, Joe, I'm going to be in the area. Can I drop by your training? The reason I need to know before is so that they don't charge you when you show up at the hotel for the training and they know that you're with me, okay? So just WhatsApp me at this number here, and then I will be sure to include you on the training. Please do it early before we fill up, so where I can't accommodate anybody else. Excellent. Thank you, guys. You guys have been fantastic. I will see you guys next week. One of my sonographers will be lecturing next week. I think one of it is cardiac and the other one maybe MSK. I'm not sure, I haven't looked at the schedule, but please tell all your doctors are missing out on these lectures, especially when the sonographers start doing it. They're much better at doing this. I've trained sonographers, but the ones that I've worked with are top notch. So please tune in next week. I may or may not be able to join, but they will be lecturing. So I think you'll have a really good lecture next week. Thank you guys, and have a great evening.